Welcome to MO Module Slango. This is the part 2 video of the eye module. In this module, we will be covering the topics of painless loss of vision, eye emergencies, and eye referral pathway. We will move on to conditions that cause painless loss of vision. This is a flow chart that helps us to get to a diagnosis when patients present with the complaint of painless loss of vision. When someone presents with a loss of vision, it is important to check the vision using Snellen's chart. When vision is normal using a pinhole, then it is more likely to be refractive error. Myopia is short-sightedness, which is common in children and can be corrected using spectacles with concave lens. Hypermetropia is a term used to describe long-sightedness and is corrected by convex lens or LASIK surgery. Presbyopia is a condition often occurs at the fourth decade of life due to loss of ability of the lens to change the convexity. It is corrected with bifocal lens or reading glasses. Next, we will move on to two other more serious conditions that causes painless loss of vision. Both these conditions cause sudden onset of vision loss that runs a prolonged course. Central retinal vein occlusion, or also known as CRVO, is when the central retinal vein becomes occluded, usually through thrombosis. Age is the most important factor since over 90% of cases occurs in patients over the age of 55 years old. Other risk factors include diabetes mellitus, hypertension, cardiovascular disease, glaucoma, vasculitis, blood dyscrasia, and smoking. CRVO further divided into non-ischemic CRVO and ischemic CRVO, each of which has implications for prognosis and treatment. Presentation is sudden unilateral blurring of vision. Fundoscopy shows tortuous and dilated central retinal vein branches, dot blot and flame-shaped hemorrhages throughout all four quadrants, most numerously at the periphery, and optic disc and macular edema, which is often described as tomato splash appearance. REPD is positive in non-ischemic CRVO. Urgent referral to ophthalmologist is warranted. Retinal detachment is a sight-threatening condition with an incidence of approximately 1 in 10,000. Patients who present with symptoms of new onset significant photopsias and or persistent new floaters should be suspected of having a retinal tear, which could lead to retinal detachment. A patient with constant, fixed or slowly progressive visual field loss should also be suspected of having a detachment until proven otherwise. Visual acuity, pupillary examination, visual field testing, and intraocular pressure measurements are important parts of the pre-dilated ophthalmic examination to evaluate patients with symptoms of retinal detachment. Additional examination is color vision and visual field. The area of visual field loss corresponds to the area of detachment of the retina. Trauma, high myopia, aphakia, pseudophakia, previous history of retinal break or retinal detachment are risk factors for retinal detachment. Patients need to be referred to ophthalmologists for laser or surgical intervention. Sudden prolonged vision loss with abnormal direct pupillary response should prompt us to look for the next two conditions: central retinal artery occlusion, CRAO, or temporal arteritis. Both conditions will cause a positive RAPD. Central retinal artery obstructions, or CRAO, causes sudden profound painless loss of vision of one eye. It occurs due to obstruction of central retinal artery due to thrombus or emboli, results in infarction of the retinal layer within 90 minutes. It gives a pathognomic appearance of cherry red spot in the ophthalmoscope. Diabetes mellitus, hypertension, IHT, obesity, and dyslipidemia are risk factors. Emergency referral is needed to save the eye. Ocular massage and breathing into the back are techniques used to help to dislodge the emboli. Ophthalmologists may start IV acetazolamide and perform a anterior chamber paracentesis. Temporal arteritis is a sudden painless loss of unilateral vision associated with unilateral headache. It may have preceded by Amaurosis fugax. Severe facial pain on chewing or pain during combing hair may be the accompanying symptoms. It is caused by vasculitis of the temporal artery, leading to inflammation of the artery and causing artery thickening. Artery eventually becomes pulseless. Increased age, women gender, and history of polymyalgia rheumatica are risk factors for temporal arteritis. Urgent referral is indicated as patient needs to be put on high dose of steroids for a better prognosis. When the vision loss is transient, amaurosis fugax should be considered. Amaurosis fugax refers to transient vision loss less than 24 hours and might signify a thromboembolic event causing transient ischemia to the optic nerve, retina, and choroid. Amaurosis fugax can be a harbinger of impending stroke and thus merits urgent evaluation. Diabetic retinopathy is a condition we as primary care doctors should be able to screen and refer when needed. Diabetic retinopathy represents microvascular and organ damage as a result of diabetes. It ranges from non-proliferative diabetic retinopathy (NPDR) to proliferative diabetic retinopathy (PDR), and as the disease progresses, associated diabetic macular edema may also become apparent. Patients can be asymptomatic or have symptoms like decreased vision, fluctuating vision, presence of floaters, or visual field defects. Diabetic retinopathy is divided into few stages. Non-proliferative retinopathy is further divided into mild, moderate, and severe retinopathy based on the severity of lesion seen in ophthalmoscopy or fundus camera. The hallmark of proliferative retinopathy is neovascularization. The most severe stage of retinopathy is advanced diabetic eye disease, which will have one of the following features: formation of fibrovascular tissue formation, or tractional retinal detachment, or dragging of retinal distortion, or ragmentous retinal detachment. Macular edema or maculopathy is a condition when fluid and protein deposits collect on or under the macula of the eye, causing swelling. It can present as retinal thickening or hard exudate in the macula and may distort a person's central vision. Patients with diabetic maculopathy needs to be referred to ophthalmology clinic within 4 weeks from the time of diagnosis. Now, we'll go on to another common condition that we see in our cases regularly: cataract. Cataract is defined as any opacification of the eye's crystalline lenses which causes gradual painless vision loss. While the majority of cataracts in population are age-related, there are also other causes such as traumatic cataract, congenital cataract, metabolic causes, and drug-related cataract. The symptoms of cataract include gradual blurring of vision at distance or near, glare, poor night vision, and difficulty in reading small prints. Diagnosis in our KK is mainly based on assessment of visual acuity and identification of lens opacity on eye examination. Examination of pupil with ophthalmoscope usually disclose subtle opacities. Small cataracts stand out as dark defects in the red reflex. A large cataract may obliterate the red reflex. Patients need to be referred to ophthalmologists for dilated full eye examination. Early detection and ophthalmologist referral is essential in infants to prevent development of amblyopia later in life. Management is normally surgical based and the usual technique is referred to as phacoemulsification. Now that we have discussed the common eye conditions that we encounter in our clinical practice, it is important for us to identify the common ocular emergencies that need urgent attention. Recognition and early referral of such condition is imperative to prevent vision loss. Below are the eye conditions that need immediate attention. As we have discussed most of the conditions earlier, we will discuss regarding chemical eye injury. A chemical eye injury occurs when the eye comes into contact with an acidic or alkaline substance. Chemical injury of the conjunctiva and cornea is a true ocular emergency and requires immediate intervention. Chemical injuries to the eye can produce extensive damage to the ocular surface and anterior segment, leading to visual impairment and disfigurement. Alkaline injuries are more destructive compared to acid injuries. The severity of ocular injury depends on four factors: the toxicity of the chemical, how long the chemical was in contact with the eye, the depth of penetration, and the area of involvement. It is therefore critical to take a careful history to document all these factors. Prior to full ophthalmic examination, the pH of both eyes should be checked. If the pH is not in physiologic range, then the eye must be irrigated to bring the pH to an appropriate range between 7 and 7.2. Irrigation is the cornerstone of managing chemical burns and should be initiated by bystanders and continued as transfer of care takes place between KK, ambulance, and the ophthalmologist. The goal of irrigation is to remove the offending substance and restore the physiologic pH. It may be necessary to irrigate as much as 20 liters to achieve this. Eyelids should be everted and any visible parts should be removed using cotton buds during the process of irrigation. And not to mention, all cases of chemical injury need to be referred to ophthalmologists without delay. We have now come to the end of this lecture. Before we end this lecture, I would like to show you a table of eye referral pathway. This table is very important to guide us on how urgently we need to refer a patient with eye complaint to ophthalmologist. With this, we have come to an end of the eye module. These are our references. Thank you for listening.